We're going to start our event back up with our first post-launch presenter being Dr. Dan Semenza, who's an assistant professor in the Department of Sociology, Anthropology, and Criminal Justice at Rutgers, Newark. And I will say we at the GVRC are really excited to work much more closely with Dan in the coming year. And with that, Dan, take it away, and I will get off your stage.
All right, awesome. Thank you so much for having me, Mike, and for that introduction. And thank you everyone else for being here and for attending. Thank you for the incredible speakers this morning. Honestly, a lot of what I present in the next half hour is going to be fundamentally based on some of the work we've already heard about, including Dr. Richardson's work especially. And so the project that I'm going to talk to you about today has been funded by the Gun Violence Research Center over the last year. And what I'll be doing is kind of giving you an overview of what the project has been, what we're seeking to accomplish, and give you a little preview of what we're finding. We're kind of in the nitty-gritty midst of doing all of the analysis and data work. So I wanted to kind of set this up and then have more to show in the coming months and more to discuss. So I'll be talking about the health-related consequences of community gun violence, and I'll be talking about it very much from a neighborhood kind of community level perspective. I want to make sure that I shout out my collaborators, Dr. Richard Stansfield, who's in my department at Rutgers Camden, as well as Brielle Savage. Hey, Brielle, who was an integral part of this project in pulling the data together and doing all of the research necessary to get the database up and running. So the background for the project, when we sat down and thought about really what we wanted to propose and what we were looking to accomplish, you know, we have all heard the term many times, especially the people that are here in this conference, of gun violence as a public health problem or a public health issue. And this project seeks to really capitalize on that and take that quite literally. In addition to some of the things that Dr. Betts highlighted about thinking circularly about processes of identifying risk factors and processes for intervention and doing that procedure from a public health standpoint, the idea here is to understand how does gun violence influence or shape community health and community health over the long term, over a long period of time. So we're not looking just for a snapshot understanding, but really trying to take a longitudinal perspective. And so, you know, in addition to wanting to really understand how gun violence affects the health of neighborhoods, we wanted to be able to do this over the long term. And we wanted to be able to do this in a way that accounted for both homicide and non-fatal shooting. So everything I talk about today is going to be, you know, having to do with community gun violence that disproportionately takes place in disadvantaged communities of color throughout cities in the United States. And there really is a total lack of comprehensive non-fatal shooting data in this country. There's no one place that you can get it, and certainly no one place that you can get it officially from the government in a standardized kind of form. And so this was a major pain point that we wanted to address when we were thinking about the research that we wanted to do. And then finally, a big part of the background here is, in addition to taking this public health issue and gun violence as a public health problem literally and thinking about it at the neighborhood level, understanding how violence exposure, and particularly firearm violence exposure, functions and operates in this country as a true fundamental cause of health disparities throughout our cities, and particularly thinking about socioeconomic health disparities and racial health disparities. So this was kind of the framework for how we were thinking about setting up this problem. I really want to call out the fact that what I'm talking about today, we are studying homicides and fatal shootings, but there is a real need to focus on non-fatal shootings and injuries in the United States. And I'll throw some quick stats out here just to kind of give you a sense of the magnitude and the relative difference between fatal and non-fatal shooting when it comes to the true numbers. So there are somewhere, depending on the year that you're talking about, 85,000 firearm injuries each year in the United States. And roughly about 40% of those are as a result of an intentional assault. So somebody intentionally shooting another person. These are not related to issues of suicide or accidental shootings or things like that. And depending on who you ask and depending on how you're calculating the different costs, there are extraordinary billions of dollars worth of costs related to non-fatal injuries that go even beyond direct medical care. This is loss of life, loss of life, the money that is incurred from that, the loss of productivity and wages. So when we put that all together, we're talking about an extraordinary cost just for firearm injuries. And what we do know, of course, is that this has a disproportionate burden among young Black and Hispanic men who are living in structurally disadvantaged neighborhoods. So when we talk about the burden of non-fatal shooting, in addition to it being very, very large, it is also not equally spread out across the population. It is harming Black and brown communities and the young men living in those places most acutely. The thing that I think a lot of people don't know and don't realize, because so much of the reporting and media outreach around community gun violence is on homicides when a person is shot and killed, is that the ratio of non-fatal to fatal shootings in the US is about 4 to 1. And so non-fatal injuries and non-fatal shootings are happening far, far more frequently than homicides. And a part of this has to do with the fact that if a person is shot, the survival rate is estimated to be somewhere between 70 and 80%. Of course, it depends on how far a person lives from a trauma center, where they are actually shot, the services that are provided around them. But if there is proper medical intervention and the wound or the injury is not fatal immediately, there's a decent shot at survival rate. The problem is, though, that there are also very low clearance rates for non-fatal shootings. And so we know that they're happening a lot more frequently, and we know that they're being cleared by the police, being solved by the police far less frequently than homicides. I should also say, like I mentioned at the very beginning, to reiterate, we're using different studies to estimate the number of non-fatal shootings, but we don't actually have official count from official data sources because there is not a way of collecting these data. The FBI collects homicide data, and that's official and that's all vetted out, but the non-fatal shootings, we do not have a singular database for that. So that's another reason of needing to scope in on this problem. And like I kind of mentioned at the beginning of this presentation, what I'm going to talk about in terms of this project draws very much on other researchers that have come before me, that have been doing, particularly extraordinary work, ethnographic work, doing interviews and really on the ground studies. So that is Dr. Richardson. It's my friend and colleague, Dr. John Rich, who is at Drexel. It is people like Ju-Young Lee, who's at University of Toronto. So there are people that the research I'm going to talk about really builds on their qualitative exploration of this kind of stuff. And we know from that research and from research that has taken place in emergency rooms and case studies that there's tremendous physical and mental fallout from incurring a shooting and from the neighborhood experiencing shootings as a whole. And this ranges from things like post-traumatic stress and depression to more physical things like chronic pain, substance use and addiction to deal with that chronic pain, paralysis, the need for colostomy bags, functional disabilities. Ju-Young Lee does a really great study where he kind of looks at gun violence survivors and talks about kind of the day-to-day stuff that people experience every day when they have been shot but recover. And that's everything from managing pain to issues with sleeping, maintaining employment, having sex, sitting down for a meal and just enjoying being at a restaurant with somebody else. These are everyday things many people take for granted and are completely called into question for people who have experienced gun violence themselves. Um, and so what this kind of results in is because we know that there's a disproportionate burden on disadvantaged communities of color, is that over time, the neighborhoods where shootings are taking place again and again and again become these kind of like survivor cities, areas where many people have been shot, where many people have a story about having been shot, about knowing somebody who's been shot, a family member, a friend, witnessing or hearing about it. And it becomes this kind of pervasive thing. And that was shown really, really clearly, I thought, in some of the clips that Dr. Richardson showed from his documentary this morning. So there is this consistent threat of re-exposure, re-victimization, and the retaliation cycles that fuel a lot of gun violence in the neighborhoods that we're talking about. And because of this kind of pervasiveness that affects the different levels of, whether you're an actual victim of a shooting, you know somebody, or you hear about it, this kind of violence exposure in neighborhoods can really be classified as a social determinant of health. And that's how I'll be framing the study that I'm talking about over the next 10 to 15 minutes or so. And so in my head, when I am thinking about this work, when I am trying to conceptualize and bring together the work of many people who have done the interviews and the actual on-the-ground experience of people who are experiencing this kind of violence, I have this little chart graphed onto my brain at this point, which is really trying to disentangle what is the relationship between concentrated disadvantage, a community or a neighborhood that has high rates of poverty, unemployment, that has higher concentrations of Black and Brown residents. What is the relationship between that and then the experiences of gun violence, and then outcomes for physical and mental community health? And how are these three things related to one another, and then how do these kind of run in cycles so that disadvantaged communities experience more gun violence, health is poorer as a result, and that then feeds back into greater disadvantage over time in those same neighborhoods. So to kind of give you a little thought into how I'm thinking about it, I think this is a good image to kind of keep in the back of your mind when I'm talking about the neighborhoods in this study. So here are the main goals that we really set out to accomplish within this research. The check mark means check, we have accomplished this goal to the extent that we set out to do for this particular project, and the little hourglasses mean in progress, and we're currently working on it. So the first goal was to build a nationally expansive longitudinal database of neighborhood level fatal and non-fatal shooting, their correlates and risk factors, and then health outcomes that are associated with these. And that is what we built, and I'll talk about that a little bit because to people outside of the research community and who are maybe not familiar with this kind of work, this is actually a big ask. This doesn't exist aside from this database. A lot of neighborhood level research that is done is on a single city or a particular set of cities. The most expansive work to date has been goes back to like 2000. So it's been about 20 years since Ruth Peterson and Lauren Cribo collected a lot of data, but it didn't have some of the things that I'm talking about. So that was goal number one, and that's what I'll be mainly talking about. And then the next steps are to examine the relationship between community gun violence and health over time. Literally running those models this week, and we are finding that there is indeed a relationship between gun violence rates and different health outcomes at the neighborhood level. And then we'll also be looking at differences based off of racial composition and concentrated disadvantage, in health that are related to community gun violence exposure. And I'll give a little bit of a teaser to that at the very end of this before we go into questions. And so in order to accomplish that first goal, what we needed to do, Dr. Stansfield and Brielle, who were the other two people that I mentioned that have really worked on this with me for the last year, is it really required going to a number of different data sources and pulling them together and joining them together at the neighborhood level. And this really speaks to the lack of data and to the lack of availability on some kind of core criminal justice and police related items is that you have to go kind of outside official sources sometimes to be able to find this stuff. And the best place right now, to our knowledge, is to get a full understanding of homicide and non-fatal shootings throughout the country is a database run by Patrick Sharkey called the American Violence Project at Princeton University. It's an incredible database. I think the site is being worked on right now, but it documents all of the non-fatal shootings and fatal shootings since roughly 2014 or so. Sorry about that. Since 2014 through 2019. We also have brought together data from a really important source called the CDC Places data, which was formerly called the 500 Cities database. And this is neighborhood level health outcomes for all of the neighborhoods in the 500 largest cities in the United States. So really, really rich neighborhood level data set. We paired that with data from the census and the American Communities Survey, as well as information on trauma centers and their locations from the American College of Surgeons. So this should give you, these are the 100 cities that we have included in our data set. And the importance here, again, is not only are we looking longitudinally, but we're looking at a nationally expansive set of communities and communities within cities across the country. And that's really important because in many studies that look at this kind of stuff, it's always relegated to a certain collection of neighborhoods in a handful of cities or a single city. And so now we're going to really be able to build some comparability and, to an extent, some generalizability, at least across large cities. So the overview for the data that we have spent the last year collecting is we're looking at roughly 16,000 census tracts, which is how we measure neighborhoods throughout the 100 largest US cities from 2014 to 2019. So that's about 6 years of data. We have information on the annual rates of both fatal and non-fatal shooting. And like I said, this is relatively unprecedented. Well, it is unprecedented because non-fatal shootings have certain data restrictions that you just cannot get this information any other way. Neighborhood level health measures, and then neighborhood characteristics, right? Really important to account for the different types and different disadvantages of the neighborhoods that we're discussing. And so for community health, I really want to focus on this for a second, because the core question that we are trying to get at is how does the rates of fatal and non-fatal shootings in neighborhoods correspond to subsequent or future types of health outcomes? And so we are looking at physical health outcomes. So these are all kinds of things like chronic issues, whether it's issues of higher blood pressure, whether it is rates of asthma, whether it's rates of depression. You can go on the Places website actually, and you can see all of the specific measurements for each one of these buckets. But we do have a number of different types of health outcomes that are kind of more chronic or long-term. And we're starting to take a look at that a little bit, but we're hoping to build this data set out even further. And we'll be able to look at the more chronic stuff with that over time. But we're also looking at how does gun violence in a community correspond to different types of risky behavior, smoking, poor sleep, binge drinking. We also have measurements of going out and getting exercise and moving around in the neighborhood, right? We would expect, and there's some research to show that if the neighborhood has high rates of gun violence, people are going to be less likely to want to go outside. They may not have access to parks where they can get exercise. So we'll be able to look at that kind of behavioral stuff as well. We also have measures of people's general health status. How have you felt over the last 14 days physically? How have you felt mentally over the last 14 days? We have measures of healthcare utilization, whether or not people are actually going to the doctor regularly. Are they getting a checkup? Are they going to the dentist? Are they getting screenings? If they are older people, for different types of cancer, for colonoscopies, all this kind of preventative stuff that you might expect people would be less willing or less able to do if they're living in a place with low access for resources, or there's a lot of fear of kind of gun violence happening in that community. And so we're building a kind of factor out of all of these different aspects of community health to understand its correspondence to healthcare. But we're also looking at functional disability. I've done some research with Dr. Stansfield that shows that specifically amongst young men in disadvantaged communities where gun violence is high, there are far greater rates of functional disability, the ability to go out and run errands, to do kind of everyday normal activities, dress yourself, take a shower and bathe yourself. You would not expect these kind of disabilities to be high rates, especially amongst young men. And yet when gun violence is high in these areas, we find that those disability rates are elevated. And then, of course, like I mentioned, in the data set, we've also calculated for every neighborhood how close or how far they are from a trauma center, because that really matters whether or not a shooting is fatal or non-fatal. It can also have implications for whether or not a shooting leads to disability or longer-term illness. And so we have that as a really important key kind of geospatial factor in here as well. And like I said, in addition to understanding the relationship between community gun violence and health outcomes, we really need to understand where the gun violence is highest and the type of community characteristics. Now, to be clear, there's lots of research that supports this notion that concentrated disadvantage is very high in neighborhoods with gun violence, where there are higher rates of poverty, where there are higher percentage of Black residents or Hispanic residents, where there are more female-headed households, unemployment rates, right? So this is typically built into a kind of index or a factor that shows that the neighborhoods that are already struggling the most also have the highest rate of gun violence. And that's really important for us, and I think really kind of more broadly, the way that the Gun Center is thinking about this kind of research is it's really centering the idea of disparity and inequality where gun violence is most effective and where it is having the biggest impact on people in terms of outcomes like health. And so we have a lot of these measures that we've really matched to all 16,000 of the neighborhoods in our database, so we can get a much more granular sense of the types of places that we're looking at and the disparities in gun violence between them. So just for the last couple of minutes, I just want to give you a sense of what we're doing, the kind of analysis that we've been running, again, without any major focus on results, because I think a lot of that is preliminary at this point. And then I want to talk briefly about next steps, in part because my brain is so focused on a grant right now that we're writing to build this out that I just need to get it into the world and talk about it a little bit and hopefully get some thoughts if people have questions. But the primary goal right now in the analysis that we're running is we are looking at longitudinal year-over-year changes. And again, we're not talking about individuals. We're always talking about rates of shootings that are occurring at the census tract or the neighborhood level. And so really importantly, we're at least first getting a sense of over time, the 6 years in our data, how have non-fatal and fatal shootings changed in particular neighborhoods? And from 2014 on, we are starting to see that there has been kind of a rise since 2014 in a lot of places, but the rises in shooting, both fatal and non-fatal, are disproportionately affecting Black and Brown disadvantaged communities, right? So you might often hear over the last 30, 40 years prior to this big spike in gun violence that we're now experiencing, that America has decreased its rates of gun violence and interpersonal community violence tremendously, and it's this big success story. But the problem is when you zoom into the communities that are actually most affected where gun violence is highest, that are the Black and Brown disadvantaged communities, those rates have stayed flat, or in many cases, especially in the last 10 years, actually gone up. So this is, again, that issue of inequality and disparity that is central to this kind of analysis. We're also going to be looking at the exponential effects over time. So how does the increasing rise of gun violence over time exponentiate to harm health disparities and health outcomes, as you're moving through time over that 6-year period. And like I mentioned, really a key thing for us is not just looking at community health as a whole, although that's really important. We want to combine these different factors around health behaviors and health outcomes and health status to think about this broadly, but we're also investigating the specific types of behaviors, right? So we are seeing that community gun violence that's higher in neighborhoods has an impact on things like exercise and sleep and smoking. That has to do, we think, with kind of fear of violence, with the stress, with the kind of hypervigilance that arises for both people who are involved in shootings and who are just community members that are hearing about the shooting. So this really gets into the nitty gritty day-to-day health of people, not just kind of the broader outcomes that you might think of when you look at this kind of research. Like I said, of course, we're investigating as we move forward with this on disparities, both socioeconomically and racial disparities, with a particular emphasis on how segregated communities that have high proportion of Black or Brown citizens disproportionately, are harmed by gun violence and those health outcomes. And so looking forward to the next steps, we're looking to keep going with this. We're looking to build this out. We want to cover a full decade, and we're writing a grant to do so now. We also want to contextualize all of this neighborhood level research with variables and an understanding of city level processes, state gun laws. We want to add this on top so we really get an ecological sense of what the risk factors and predictors are of gun violence and how this harms health over time. So that means accounting for things like availability of guns, policing resources, community relationships with the police, and then of course the actual physical environments of neighborhoods. And so we'll be building out on the analysis of violence exposure and health, kind of looking at it from both angles and both directions, and I can talk more about that. And we're also looking into some really cool new methods. One is coincidence analysis that will actually identify pathways and specific combinations of risk factors that put neighborhoods at greatest risk for gun violence. So it's a lot of really interesting, I think, and exciting stuff that we'll be moving forward on this. And I'm looking forward now to any questions that you all may have. Feel free, please, to email me if you'd like to talk further. If you want to collaborate on this kind of data, I'm always down to collaborate if people are interested. And of course, you can reach me on Twitter at @DSemenzCrim. You'll see me on Twitter with the GVRC. So thank you all so much.
All right, Dan, thanks for that great presentation. I know we don't have a ton of time, but I also know we have a question from the audience, and I'll wait for that to pop up before. There we go. So from Karen Cantor, what about the Gun Violence Archive as a source of data collection?
Great question, Karen. So the American Violence Project, for their non-fatal shootings, they actually draw very substantially on the Gun Violence Archive, and the methodology at the American Violence Project has a way of making sure they identify the accuracy and the proper data collection methods from GVA. So it's kind of like a second level of collection from the GVA that I think really adds to make sure that we can be confident in the data. And so you're right on there that this is drawing from that, and we are using that within this project.
Great. Okay. And a second question, actually, I came up with on my own before this session ended, so I'm going to sneak one in myself. It's just so I know you've got this amazing, rich 6 years of data going up through 2019, and I'm wondering how, sort of what your thoughts are on how this will inform the sort of uptake in gun violence in 2020. So how much do you think you'll be able to model and sort of maybe anticipate what we know occurred at the end point of where this data collection stops?
Yeah, so I think, the data collection stops at 2019, but what we're going to be able to do is understand some of the dynamics of, what is happening at the neighborhood level, especially when it comes to some of those predictors of concentrated disadvantage and those different characteristics. So I think we'll be able to confirm what some other smaller neighborhood studies have already shown in that this stuff really matters. But this is one of the reasons why we want to expand the data. What we're hoping to do is expand the data through 2023. So it would be a data collection continuing for the next 2 years, because then we'll have that discrete point in which we can look at the differences, kind of pre-pandemic, post-pandemic, and we'll be able to include things like community-police relationship, changes in gun laws, stuff like that. So we'll be able to predict some with this timeline, but getting that next data step is going to be really critical for the question that you're asking.
Yeah. Okay. Well, thank you again to Dr. Semenza. And oh, wait, we got one last question. Really impressive scope of work. To clarify, are you able to connect individual level data, such as from medical sources, with neighborhood level data from exposures?
Yeah, so we have been primarily focused on kind of the higher levels of the socioecology, neighborhood, city, state. That's where we're going with it. But there's no reason that we wouldn't be able to theoretically connect individual level data if we had address data and we had the ability to connect with, Medicaid files or something like that. There should be a way because we have the GIS join indicators for all of our neighborhoods. So David, please do reach out to me because we can talk about this more. It would be a big lift in terms of doing that connection, but it's a valuable one to do for sure.
So we had two more questions just pop in, both of which are really great questions, and unfortunately we're out of time. So I hate to cut things short, but I also know I don't want to jump ahead. So I don't know if David and Dr. Richardson, if you might be willing to even ask these questions on Twitter, and we can continue the conversation that way while we move forward with the next conversation too. That way I don't cut off this conversation from happening. So I think it's really important, and I also don't steal time from the folks coming up next. So I want to quickly thank Dr. Semenza again for a great presentation.